does come in syrup for kids. It's often one of the drugs of choice. It's fairly inexpensive, very low side effect profile compared to a lot of your other drugs. Can be used for tonic-clonic and partial seizures. It basically affects sodium channels. However, one of the things that you will see is that it can have analgesic, anticholinergic, antidysrhythmic, antidepressant, muscle relaxing, and sedative effects. So Tegretol, a lot of times you will see it used as not only an anti-seizure medication, but you may see it used for cluster headaches. You may see it used for some of your peripheral neuropathies. You may see it used occasionally for your facial spasms or tics, hiccups a lot of times. And we're not talking, like hiccups, boo, and it goes away. We're talking about patients that have hiccups for 2 or 3 days straight. Took care of this guy one time that had hiccups for a whole week. And we had to give him Tegretol to get them to go away. Typically what you're going to see with Tegretol is that the therapeutic range is about 4 to 12. And you will make sure that you follow through with checking those levels. No matter what your problem is, whether you're giving it for neuropathy or seizures, you always want to check that therapeutic level because you don't want it to be toxic. One of the things you need to remember is that it does reduce the effectiveness of birth control pills, so they perhaps need to use another birth control method. Just some side effects and drug interactions. Typically, because it is one of those medications that controls sodium balance, you don't want to give it MAOIs. Trileptal, another drug in this class, very similar. You may see it used as a mood stabilizer. So you may see this being used in your patients with bipolar disease as well. Now Neurontin, like I said, the majority of time when you see Neurontin used, it's used as a drug for peripheral neuropathy. I'm going to tell you occasionally we will use it for seizure control, but what you will see is that instead of 200 or 300 twice a day that you see for peripheral neuropathy, you will see like 1,200 milligrams be given for seizure control. It's much higher dose for seizure control than it is for peripheral neuropathy. Valproic acid or Depakote, you can also see for seizure control. Again, we use it for bipolar. All right, Neurontin. Basically, one of the things you need to remember about Neurontin is that it's not metabolized. It's excreted unchanged by the kidneys. So you can use Neurontin in patients with hepatic impairment, but you cannot use it in people with renal impairment. Because if they're not able to excrete it, the levels can become very, very high. It's really interesting. Neurontin can be given for hot flashes too. Some of the side effects. GI symptoms, drowsiness, fatigue. One of the things that you want to make sure is that you don't give it within 2 hours of antacids, either before or after the drug dose.
What does it mean when it says morphine and hydrocodone can cause additive effects? I mean, do you know exactly what that is?
Basically, what you're going to see is that Neurontin can cause sedation. If you give morphine and hydrocodone on that, it can cause more sedative effect.
Because my mom takes the hydro and Neurontin.
And that's probably okay once you build up a tolerance to it. But when you first go on one or the other, or both come on both of them, then you may see more sedation to start off with. But typically, tolerance is developed to that effect. Now, Depakote. This is the one we usually see for absence seizures or partial complex. Remember, those are the temporal lobe epilepsy. You can also see it used for migraine, mania. With Depakote levels, therapeutic trough level, and what do I mean by trough level? When the level is the lowest right before you give the next dose, right? Okay. The level is 50 to 100. Depakote, again, higher than normal risk of birth defects if taken during pregnancy. You need to educate the women of childbearing age to have reliable birth control. One of the things that I will tell you is that if these women do want to have children, they need to have a very good relationship with their neurologist, and their neurologist has to have a good relationship with their OB, because you have to very carefully monitor that progress of that pregnancy throughout. What I'm going to tell you is that if they continue a lot of these medications during pregnancy, not only does it increase the risk of birth defect, but the risk for autism is greatly increased as well in the children that are born. So what you will see is that a lot of times they may come off on a lot of these medications during first trimester to some other medications. And then as the child develops out of that first trimester, they may go on some of these medications. But the most critical point is first trimester of pregnancy. So if these women do become pregnant, it needs to be a planned process. Okay? Just some other things here. Okay? Now, questions about seizures. Let me show you a few other seizures that look a little different than what we saw before. The things you're going to want to think about with your seizure patients, these are your priority nursing diagnoses. Ineffective airway clearance, risk for injury related to that movement, ineffective breathing pattern, anxiety can be from the patient, the nurse, and the family, okay? So those are going to be your priorities. What we're going to think about doing is this. Remember I talked to you about that tongue. You really don't worry so much about them biting it. If they do bite it, that's okay. It heals. Tongues are the only thing that you really never have to put stitches in, because they heal spontaneously within 1 to 2 days, unless it's completely off, and that's usually not seizure activity. However, it can occlude your airway, and those secretions can pull. Basically, what you may see is that turning that patient on their side allows those secretions to drain, especially if you don't have your suction already set up. Which, if you have a patient on seizure precautions, oxygen, suction should be in that room. You should not have to go get it. You should not have to set it up. It should already be there. You're going to want to loosen the clothing around their neck. You're going to turn their whole body to the side, not just their head. but their whole body. We do not force anything into the mouth. Now, you saw that she used that Yonker suction, which is that long tube that has that hard plastic. That does not go between the teeth. It goes between the teeth and the cheek, okay? So that you can suction. Very similarly to what they do at the dentist office. But you don't put it between their teeth. We're going to give oxygen. Like I said, it's easier to do a face mask than try to put nasal cannula on someone that's doing this. Okay? Basically, if you have a person that has a history of respiratory issues during seizures, I would suggest that you put them on a cardiac monitor or at least telemetry and have a pulse ox that you can put on their finger. Okay? Never use that tongue blade. The other thing that you're going to want to do is those padded bed rails. This is key. That bed needs to be in the low position at all times. Number one, it should be anyway, because that should be the last thing you check before you leave that patient's room. But with these people, it's extremely important that that bed be in low position, because if they do fall, you don't want it to be from the orthopedic position. Okay, you've ever heard the difference in with the, I don't know, there's a book out called The House of God. It's a wonderful book that's hilarious as all get out after you get finished school. But what he talks about is the different bed heights. You know, like if the patient falls out of the bed at the top height, it's neuro, because they're going to fall and get a head injury. Next lower level is orthopedic height. They're going to fall out and break a hip. Next is, get scrapes and bruises. And the lowest position, they're just going to stay where they are. But basically, that bed should always be kept in the low position, because you don't want that patient to fall and get a head injury or break a hip. If they're hospitalized for seizures, or if you suspect alcohol or drug withdrawal, get IV access in as soon as you can. And you're not going to have one of these little PO 22s. You want to have a 20 or an 18, something that's got a fairly large vein that you can give some meds through if you have to. 22s are okay for just plain old fluid, but I want to have that IV in a position where I can get to it and it's protected, that it's not going to pull out whenever this person is flailing in their seizure. If that client has an aura, instruct them to lie on the floor or in the bed to prevent injury. Remember, head in the lap or on a pillow or on that bed. Now, it's really sort of neat to work with some of these patients that have seizure dogs, because that dog will alert you to when that patient's going to have a seizure. And it's really, not one of the things that every dog can do. Those dogs are expensive. We're talking $15,000 to $20,000 for training on those dogs. So if they have a seizure dog, you better learn to figure out what the clues are, because that dog will give you some good clues as to what the care of your patient would be. Now, some of the diagnostic procedures, EEG, electroencephalogram. Basically, what you're going to see is that there will be leads, usually on the scalp leads, that will have numerous spots, both sides of the head, and they will run an EEG. Now, typically with an EEG, you may only do 1 or 2 hours or you can do continuous monitoring like you would do with our patients that are in for seizure monitoring. A couple of things I'll tell you to remember is that the way that they put these leads on is with something called collodion. It smells like nail polish, because basically that's sort of what it is. Basically, to get it out, there is some oily goo, like Goo Gone will get it out. Nail polish remover will get it out. Typically, your good EEG techs will take it out for them, but a couple of hair washes and the rest of it should come out too. CBCs or any other blood work are important because we're looking for metabolic causes of that seizure activity. Lumbar punctures are often done because we might suspect either encephalitis, which is a viral inflammation of the brain, or meningitis, which can be either bacterial or viral in origin. Now, CT scan or MRI are extremely important. One of the things that you will see is the most common presentation of brain tumor is a seizure. So if you've had a patient that has a generalized tonic-clonic seizure and they've never had one before, I would be highly suspicious for brain tumor. So they will do CT or MRI to rule out. The other thing is drug levels. Looking at what their anticonvulsant levels might be, because if they're subtherapeutic, that makes them at greater risk for seizures. Now, one of the things that we do with children that they've had some various success with is that with children under the age of 8 with seizures, they have what we call the ketogenic diet. Basically, what we are doing is inducing DKA, or ketoacidosis, in these children. We want a high intake of fat, adequate intake of protein, very low carbs. Very low carbs. And what you will see is that ketosis that's caused by the diet produces an anticonvulsant effect. And so what you see with these children that adhere to this diet, the incidence of their seizures is greatly reduced. Now, that's not without concern. Constipation. High fat, high protein is not a lot of fiber. So constipation is an issue. Hyperlipidemia is also an issue, because one of the ways that you can get that high intake of fat is bacon. Bacon. Hyperlipidemia is going to be one of your problems. And lastly, you're going to see kidney stones. Think of it, high fat, protein, you're going to have a buildup of uric acid. And so you will see kidney stones that will occur in these small children. One of the things that you want to make sure is that if these people are on these ketogenic diets, that they have adequate fluid intake to flush that uric acid from their system. Now, let's take a closer look at some meds.
Yes, this is my.
This is the one that has seizures. Basically, the choice of medication is dependent on the seizure type and characteristics. Treatment is very individualized. What you're going to see, excuse me, most common side effects and precautions, there are many of them. And it will depend on the type of medication they're on. What you would see for an absence seizure is not the same medication that you will see for a generalized seizure. It will depend on the symptoms and signs and symptoms that these patients have as to what medication they'll be on. The last thing is that typically there are very few people that are on what we call monotherapy, meaning only one drug. The majority of your patients that have seizure problems will be on 2 or more drugs. And the problem is, in order for those drugs to be effective, they have to be taken on whatever schedule that person is prescribed. And they need to be in those therapeutic ranges. Okay? How do they work in the body? Well, basically what these meds do is they suppress neuron discharges and prevent that abnormal focus or that abnormal area of the brain from forming or spreading across the brain. They control the movement of electrolytes like sodium, chloride, or calcium. Okay, think of them as sort of like calcium channel blockers for the brain, or sodium blockers. Or they affect neurotransmitter balance, like GABA. Or they block synthesis, uptake, or activation of receptors, like acetylcholine, or serotonin, or norepinephrine. So what these do is it depends on what the specific problem might be that you're going to see what drugs that you'll find their order. Couple of things across the board for all of these medications is that the majority of them are metabolized in the liver and they're excreted by the kidneys. So they have to be used with caution with patients with hepatic or renal dysfunction. So if I have problems with my liver, what am I more likely to see in that patient that has a seizure disorder? Toxicity. Same thing with kidney dysfunction. Okay? I'm likely to see toxicity occur. What you will see is that a lot of these drugs, people will develop tolerance to them. And you will see that the dose will have to increase in order for them to be as effective. But you have to be very careful because as your level increases, a lot of times there's a very, very fine line between effective range and toxicity. So what you often see is that they have to take them off of this particular drug, try them on another drug for a while so that their tolerance goes away, and then try them back on that other drug. Ooh, what did I do? Okay. They have to be individualized. What's effective for one person is not for another. What works for one type of seizure may not work for another, even within that same person. One of the things you need to do with teaching is they should never stop these medications abruptly. Because that is going to put them at great risk for status epilepticus. Now, for all of these medications and other generalities, monitor the level of consciousness. A lot of them can cause drowsiness, but that usually improves in a few days to a week. A lot of them can also cause slurred speech, confusion, or incoordination. And you, as the nurse, have to assess, is this a drug effect, or is this person having a stroke? They need to avoid hazardous tasks and use caution because of risk for injury or falls. In other words, no operation of heavy machinery or driving until the effects of those medications are seen. Which brings me to a point. In the state of North Carolina, you are not supposed to drive unless you've been seizure-free for a year. However, it is not a reportable condition. So, what you're supposed to do as the licensed driver that is competent and caring about your fellow man is if you have a seizure, you're not supposed to drive for a year. Doesn't say how you get to work. Doesn't say how you do whatever. Your doctor does not have to report that you had a seizure to the DMV. So, how often do you think that rule is followed? Not very often at all. Couple of other things for all of these meds. Check liver and kidney function frequently. Some of these medications require fairly frequent monitoring of not only therapeutic level, but of those AST, ALT, BUN, and creatinine. Okay? As a general rule, the majority of them cause photosensitivity. So these people need to wear sunscreen. They need to always check with their pharmacist before taking any prescribed or over-the-counter medication. Don't stop them suddenly. It can increase the risk for depression, suicidal ideation, and psychoses. Okay? Ginkgo, St. John's, and grapefruit juice can alter therapeutic ranges for most of your anticonvulsants. A lot of them will cause significant weight gain. Some may cause anorexia. How many women do you think are going to stay on a medicine that causes significant weight gain? Not very many. A lot of them are willing to risk the seizures. Most women will stay on something that causes anorexia, though. I can tell you that. It can cause nausea, sometimes acne-like skin eruptions. Now, this is one of the things that I will tell you. Even though generic brands are supposed to be bioequivalent, I have seen more patients go from generic brand to generic brand to generic brand and have seizures because of that. A lot of the neurologists that I work with will not prescribe generic anticonvulsants. They want the name brand stuff because they know that they're always going to get this company's medication. Okay? Even though those generics are supposed to be bioequivalent, they're supposed to be the same thing, they will vary slightly. And you're going to see that it will require a different dose to get the same effect. Well, that's okay as long as you stay on the same generic from month to month. But what happens when you go to your local Rite Aid or CVS? Well, they have a 6-month contract with this one company because they can get that drug cheap during that 6 months. Well, in the next 6 months, it may be a different company. And so what you will see is that the drugs may change frequently. And so your therapeutic range is going to be like this. And those patients are going to be greater risk for seizures. Be careful about using generics. Many of those, what you will see is Stevens-Johnson syndrome. And I know you've heard about Stevens-Johnson's for your entire nursing career. Well, this is what Stevens-Johnson's looks like. Basically, the epidermis is going to separate from the dermis. It starts off as a rash and blisters development. The skin basically sloughs off. It's like a burn.
Doesn't it also cause internally though?
It can be life-threatening because a lot of times it can be esophageal. Okay? And think about that. If I have esophageal blister and burns that look like this, what am I going to worry about? Swallowing. I'm worrying about my airway because of swelling too. Stevens-Johnson syndrome. It'll be one of the reasons why they will abruptly stop those medications. But they may have to cover them with some other seizure medications. Now, state of North Carolina just recently approved the use of cannabidiol or medical marijuana for seizure activity. Cannabidiol or Epidiolex is the drug company version of medical marijuana. It's the non-psychoactive ingredient. One study, however, that I read recently showed a 50% reduction of seizures in about 39% of patients. So that meant the other 61% showed no effect. Basically, what you have to do is you have to monitor the serum levels. In 47% of your patients that took the cannabidiol, they had increased seizures or new seizures in 21%, fatigue in 14%. About 1% required intubation, and there was one death. Okay? It's not the medical miracle that a lot of people think it's going to be. Now, this is with the pure cannabidiol that's processed by a drug company. This is extremely expensive. Like $400 a month. A lot of your patients that will be using this medical marijuana for seizure control will not get it from drug companies. They will be getting it from like your joint shops, I guess. I don't know, wherever they're going to sell it here in North Carolina. I know in Colorado you can go into the medical marijuana dispensary and get it. But I don't know what we're going to do in North Carolina. But we'll see. But remember, it is the non-psychoactive form of the drug that decreases the seizures. It's a pill. It's a pill, like Marinol is. It's not the smokable type. No. That's okay. Now, barbiturates. Basically, barbiturates enhance the action of GABA in the brain. With barbs, phenobarbital is the drug of choice that you'll see used. There is potential for dependence and abuse. It can also cause respiratory depression. It's inexpensive and very long-acting. My cat's on phenobarbital. I get 100 pills for $4. It's usually used to treat clonic tonic seizures and some partial seizures. Okay? Phenobarbital for your patients, usually you will see 15 to 30 milligrams a couple times a day. It can be given with patients with status epilepticus, febrile seizures, or to treat eclampsia, like the seizures when they're preeclamptic. You can give it PO, IV, or IM. Phenobarbital can cause agranulocytosis. Respiratory depression is the one you're going to worry about the most. Bradycardia, CNS depression, and coma. You never should stop. Just stop it. It needs to be tapered. Some of the brand names that you'll see, phenobarbital or luminol. Primidone is also a barbiturate that I see used quite a bit for seizure control. Now, one of the things that you need to remember with phenobarbital, if you're giving that IV, it needs to be a slow push. No more than 50 milligrams per minute. No more than 50. Because if I'm giving it in status, I'm loading it at 1,000 milligrams. Phenobarb basically interacts with a lot of other meds. You need to watch those levels closely if you're giving it with Depakote. Normal phenobarb level is 10 to 40, but that can increase with long-term use. It's really interesting that in cats, that's the normal level too. If you give DIG and phenobarb together, your DIG levels will go up. I'm sorry, they will go down. DIG levels will not be therapeutic. Interacts with Coumadin. And it can either increase or decrease clotting times. Who knows? It's not recommended to give it with Coumadin. This is just your barbiturates as a general rule. This is one of the key things you need to remember, guys, is that remember a lot of times with your patients that are seizuring, they're young women of childbirthing age. Phenobarb in particular, and a lot of the other medications are contraindicated in pregnancy. You need to have them take a reliable birth control method. Benzos. Diazepam, clonazepam, lorazepam, all the PAMs. Benzodiazepines. Valium. Typically what you're going to see is if you're going to give Valium or a benzo in someone that's in status, neurologists tend to use Ativan. Your surgeons tend to use Valium. Don't know why. But both of them enhance the action of GABA. Onset is very fast, usually as little as in 60 seconds, and you can break that status. But Your benzodiazepines, as a rule, can cause hypotension, tachycardia, edema, cardiovascular collapse, drowsiness, fatigue, ataxia, dizziness, vertigo, urinary retention, and laryngeal spasm. So, what am I really going to be worried about with these patients? Airway. Respiratory depression is going to be one of your big things, and laryngeal spasm is not one of the things that you want to see them having. Typically what you will see is that Valium or Ativan, because their benzos increase the risk for substance abuse or dependence. You may also see them being used to relax a patient prior to a procedure, like on call the MRI or on call the CT scan. They can be given PO, IV, or IM. And in kids, a lot of times we will give them PR, per rectum. If you have someone on benzos, do not give if they have alcohol intoxication, because it will have an additional sedative effect. They're also contraindicated with narrow angle glaucoma. You can't stop suddenly or withdrawal will occur. They can cause birth defects. So typically these are not medicines that are given during pregnancy. They are also secreted in breast milk. So if mom plans to breastfeed, they either cannot take these medications, or if they have to take these as seizure control, they cannot breastfeed. Because you can cause CNS and respiratory depression in that infant. Benzos. This is one of the things I want you to know. Ramazicon is benzodiazepine receptor agonist that reverses the CNS depression from Valium, from Ativan, from any of your benzos. With a benzodiazepine overdose, Narcan will not do you any good. You have to give Ramazicon or flumazenil. Okay? Which, one of the things I would tell you is that you need to start learning these generics, because NCLEX no longer gives you this one.
But that was 2016.
They were
We were told 2016.
Yeah, 2016.
Not anymore. I looked on the frequent FAQ list on National State Board. They only use generic now. A lot of drug interactions. Tagamet or cimetidine, basically, with your benzodiazepines, they can worsen Parkinson's symptoms. They will increase phenytoin levels if they're given concurrently. Remember, your benzos can cause a hypertensive crisis if given with your MAOIs, like your Nardil or any of the other MAOIs. Okay. Hydantoins. All right, these are the ones that you're going to see used quite a bit with your patients that may have tonic-clonic seizures. Phenytoin or Dilantin is the one that you see most often used PO. Fosphenytoin or Cerebrex is the ones that you see used IV. This is an IV formulation. The reason that they came up with fosphenytoin is that IV phenytoin is an extremely dangerous way to give it. Okay? We'll talk about that in a little bit, in just a second. Basically, Dilantin slows the influx of sodium ions and slows the spread of abnormal discharges. It's often the drug of choice for many types of epileptic seizures. It has less CNS depression and less probability of abuse. However, a lot of your neurologists will use newer medications, but you'll see some of the people just be on Dilantin as well. It's used for it's effective with all types of seizures except for absence, and it's used for IV and status. Typically what you will see is that with someone with status epilepticus, they will order IV Ativan, and then they will, what we call, load someone with phenytoin or phosphenotoin, about 1 gram or 2 grams, in order to keep that seizure sort of tamped down. You can see it used to treat ventricular tachycardia, especially if it's induced by dig toxicity. That's one of the very rare uses. Sometimes you will see it used for headache, especially migraines or cluster headaches. You may also see it used for diabetic neuropathy or neuropathic pain. Okay? But remember, even though it's used for diabetic neuropathy, it's still an anticonvulsant, and you cannot stop it abruptly. This is one of the key teaching points for your Dilantins or your Hydantins. They can cause gingival hyperplasia, meaning that the gums grow over the teeth. The way that you prevent that is good dental care, brushing and flossing. Okay, if that's not followed through, I've seen gum tissue that had to be removed because it completely covered the teeth. Vitamin D and calcium supplements usually are necessary because it does tend to demineralize bones and cause bone softness, and these people are at greater risk for osteopenia or osteoporosis. They need frequent labs to check the blood levels. Therapeutic is 10 to 20. Therapeutic is 10 to 20. Therapeutic is 10 to 20. What's the therapeutic, Jeff? Okay, 10 to 20. Do not give it too quickly with IV push. It can cause cardiovascular collapse. Okay? Typically what you're going to see is that you don't want to give more than 50 milligrams per minute. Typically, if I'm loading someone on 1,000 milligrams, it will take me 25 to 30 minutes to push that med in. And it is a push. You cannot hang Dilantin. You cannot hang Dilantin. That's why they went with the phosphenotoin. You can do that in a mini bag and hang that. Now, a couple of things. If you're giving it IV push, you always want to have a cardiac monitor, because what can it cause?
Dilantin.
Or phosphenotoin either.
Cardiovascular collapse.
Cardiovascular collapse. All right. Cardiac monitor. The other thing is that it is only given with normal saline. And you're going to administer it through a filter of some sort. These are some of the side effects. Lethargy, headache, drowsiness, confusion, coma, seizures, bradycardia. Well, it causes seizures. Why are you giving it? to treat seizures. Well, give it too quickly, it'll cause seizures.
Stop it.
VFib, hypertension, weight loss, liver problems, agranulocytosis, thrombocytopenia, aplastic anemia, and rash. Yeah, it will cause a rash, and lots of times you will see a Dilantin rash. And it sort of looks like the measles. Typically what you're going to see is that it's going to be a rash on the chest. Typically if they develop that rash, they'll take them off the Dilantin because the person is at risk for Stevens-Johnson's. Now, this is also what happens. This is what that gingival hyperplasia looks like. You can see how the gums are going over the teeth. Okay? Brushing, flossing. This is what happens if you give IV Dilantin in a vein that is not a central line. It will extravasate and it will cause tissue necrosis. If you've got an order for IV phosphatonin or Dilantin, I typically like to use a central line or at least a large bore catheter that I am very confident is in that vein. Because this will happen if you don't. If it leaks into the tissue. This probably will require skin grafts to close. It interacts with a lot of drugs. However, one of the things that they don't want you to give Dilantin is Coumadin. It increases the half-life of Dilantin and it can cause toxicity. It also increases levels of Coumadin. So, if you have someone that's on Dilantin and Coumadin, they can be toxic on two different drugs. So they typically do not put people on Dilantin on Coumadin. Alcohol use, barbiturate use can increase the levels of Dilantin. Now, you will see people that are on phenobarbital Dilantin as their seizure medications. But what you have to do is to make sure that you check the levels of both of them fairly frequently. It's not a good choice for patients that are diabetic because it will cause decreased blood sugars and poor blood sugar control. Don't stop it abruptly. It can cause status. All right, let's take another break. Major motor. Now, one of the things that I will tell you is that there are a couple of things that they would have gotten yelled at for in that situation. Number one, if this patient is there for seizure monitoring, you do not stand in front of the patient while they're doing the monitoring, or otherwise the doc can't really see what's going on with that seizure activity and correlate it with the EEG. One of the things you want to do, especially if you're in those rooms over on Northeast, is you stand at the top of the bed so that they have a full view of the camera. The other thing you learn not to do is to pick your nose or to scratch your, because you're on tape. Okay? And they do keep those for, it's a 24-hour. So the bathroom is the only place that those are not monitored. That's why whenever you have a patient that's on seizure monitoring, if they need to go to the restroom, that someone has to accompany them. One of the staff has to go with them to make sure that they're safe in that bathroom. Now, with those types of seizures, there's also a condition called status epilepticus. Status epilepticus is an emergency situation. basically, you have seizures that last more than 5 minutes, or repeated seizures that occur over 30 minutes or more. It's a potential complication of all types of seizures, though you see it most commonly with the generalized tonic-clonic seizures. Okay? Basically, what you worry about is anoxic brain injury because of that increased use of glucose and oxygen. The most common causes that you will see are infections like encephalitis or meningitis, alcohol withdrawal, head trauma, cerebral edema, like you see after head injury, or with hyponatremia, okay? Or other metabolic disturbances. The most common reason that people go into status is abruptly stopping their anticonvulsant medications. They come off of those meds and they drop their anticonvulsant level and they seize. Okay? This is one of the things that I want you to understand about Neurontin. Why do we typically give Neurontin, guys? Nerve pain. What is the classification of Neurontin? Yes, gabapentin is the generic name. But it's an anticonvulsant. It's an anti-seizure medication. Even if that patient has had no previous history of seizure, if you put them on Dilantin or Neurontin or Tegretol for nerve pain, and they stop it abruptly, they are at great risk for developing status epilepticus, even if they've had no previous history of seizures. So you have to be careful about if you've had someone on long-term Neurontin for nerve pain, they typically will taper them off of that instead of abruptly stopping it. Status basically is an emergency situation. It requires immediate treatment. And these are our priorities: airway and oxygen. And typically what we're going to do is give IV medications like Ativan or lorazepam or Valium or diazepam. And those are both what? Classification? Benzodiazepines, correct? To try to break that status. Okay, what we want to do is to decrease the amount of electrical firing so that that patient is no longer having those looping seizures or prolonged seizures. For lorazepam, IV push. The dose is 4 milligrams over 2 to 5 minutes. And you can repeat that in 10 to 15 minutes, but the max dose is going to be 8 milligrams. 4 milligrams slow over 2 to 5. Max is 8. For diazepam, you're going to give 5 to 10 milligrams IV push over 2 to 5. And you can repeat in 5 to 10. Max dose is 30 milligrams. Read the red letters. Watch for respiratory depression. The higher the dose, the more likely this patient is going to stop breathing on you. If I am getting anywhere near that 30 milligrams, I will already want respiratory therapy at my bedside. In fact, if I'm given more than 10, I want respiratory at my bedside. First of all, I want to make sure that my airway is protected, and the best person to do that is my respiratory therapist, right? And since it's totally beyond my scope of practice to intubate in the hospital, I want someone that can do that, protect that airway. Status is a condition that can cause death, because what happens is that once that oxygen and glucose supplies are gone, you're going to have a patient that's going to stroke out and have an anoxic brain injury that will eventually lead to cerebral swelling and brain death. Okay, so you don't want this to occur. Now, assessment of these patients that have seizures. Note the description and the length of the seizure. You want to note if an aura occurred. Did that patient lose consciousness? Those are assessments that you may have to get from your observers or your family members that were in the room. Because if you don't have these people on seizure monitor, you're probably not going to be in the room whenever that seizure starts. Okay? One of the first things I do is I look at my watch or look at the clock on the wall and figure out how long the seizure is lasting. Typically what you're going to see, even the most violent tonic-clonic seizures only occur 1 to 3 minutes. But it may be one of the longest 3 minutes of your life because you're trying to figure out what's going on with this patient. Okay? Think of getting this routine in your head. It's really funny that one night after Christmas, my cat started having seizures, just out of the blue. And I'm sitting here, I'm timing, and I'm getting ready to say, Cricket, I want you to remember apple, ball, and cow. And I'm thinking, the cat's not going to remember that. Or even if she does remember it, she's not going to be able to tell me. So anyway, it's just so ingrained in me that I do it with every seizure. And so anyway, I'm describing this, and I'm describing how long it's post-ictal. Take her to the emergency vet. I said, the cat just had a tonic-clonic seizure, and the vet's, I'm giving him, it had this long, she's been post-ictal for this long, she's, had generalized movement of both arms and legs, she was incontinent of urine, not of stool, and he looked at me like, I work with seizure patients. Oh, okay. He thought I'd Google it on the internet. But no. But anyway, it's get at routine. You need to know exactly how long it lasted, because if it lasts longer than that 5 minutes, then you've got that emergency situation. Okay? These are some of the things you want to note. What time did that seizure begin? Did the client experience any warning signs? Were there auras? Typically what you will find is your patients that have temporal lobe epilepsy, the majority of them will have auras. Some of your patients that have generalized tonic-clonic have them, some don't. Did that client lose consciousness? Okay, typically if you're talking to them and they're able to respond back to you, they did not lose consciousness. The guy with the temporal lobe epilepsy, you notice the wife kept trying to talk to him, and he did not respond until after the seizure quit. Okay? Did something unusual happen that could have stimulated the seizure? Head injury? Flashing lights. We have a group of people that we call having photic seizures. I don't know if you've seen in the literature, but video games a lot of times will trigger seizures in susceptible populations. Those wonderful flashing strobe lights in a lot of your haunted houses and discos and things like that may cause seizure activity in people that are photic stimulated. And that's why they have that warning label on them whenever you approach them. We also have had some people that have been stimulated with the signal lights, the flashing red stoplights, traffic lights, with seizure activity. So there are a lot of things that will trigger them. Typically, one of the things that we use to stimulate seizures is those photic lights. We also will stimulate them by hyperventilating. Hyperventilation also will trigger seizures in susceptible people. Sleep deprivation triggers seizures. And a lot of times what you'll see is that we will use those differing things to try to trigger them so that we can catch them on film so that you can see. Did that patient cry out at the beginning of a seizure? Typically what you will see, very similarly to what that guy did with the tonic-clonic seizure, he had that sound. Basically what that is air being forced out of the lungs by that stiffening of the muscles against a closed glottis. And it typically will occur with that tonic-clonic seizure. Did the client look to one side? Okay? And you saw that what he did is that when he had his head, he turned his head. Typically what you will see is that with seizure activity, they will turn their head to the side of the brain that is affected. So that's very important information to be able to tell your physician. Did the client lose bowel or bladder control? Typically with your generalized tonic-clonic seizures, they will be incontinent of urine because they're not able to control, because remember, bladder control or inhibition is controlled by the frontal lobe. Okay? That's why we can't potty train kids until their frontal lobes start to develop. In other words, if you tell me that your kid's potty trained at 12 months, I will say mama is trained, not the kid. Okay, because mom recognizes what the signals are. But what you're going to see is that because that inhibition is decreased, you will see incontinence of urine. Occasionally bowel, but not that common. The client typically will have increased secretions, and you saw them using the Yonker suction to suction that patient with tonic-clonic seizures. Typically, the secretions increase because they can't swallow during the seizure activity, and you may have drool or buildup of saliva in the mouth. Okay? One of the things that you also want to see is what time did that seizure activity stop. Also measure how long that they had that decreased level of consciousness or that post-ictal period. Typically what you're going to see is anywhere from 1 to 2 to 4 to 8 hours, depending on how violent that seizure was. Okay? Now, one of the things I did not put in the lecture, but what you will see, especially if you work on the neuro unit, you may hear what we call psychogenic seizures. Psychogenic seizures basically are not true seizures. They are people that have seizure-like events from some psychological cause. Typically, what you will see with psychogenic seizures is a variety of things. Okay, you saw with this guy, tonic-clonic movements were symmetrical, right? Okay, in the ER, you see a lot of seizures that do this. This is not a seizure. That's psychogenic. Okay? A lot of times people with psychogenic seizures learn to pee on themselves because they actually know that that's one of the things you're going to assess for. But psychogenic seizure is not true seizure activity. It is an event that usually occurs because somebody gets secondary gain from it, i.e. they get attention where they may not have attention in their life, or it's very much like your Munchausen by proxy. Okay, they get that secondary gain from that seizure activity. But psychogenic seizure will not show any seizure activity on EEG. And that's one of the reasons why they do those seizure monitorings, to see if they are true events or psychogenic. Okay? That doesn't say that they're fake. There's a reason that that person is having this behavior. Okay? And what you do to treat the psychogenic seizure is you treat the need. You don't give them drugs to treat the seizure because it's not true seizure activity. Okay? All right, let's do one more slide and then we'll take a break. So, after the seizure, during this post-ictal period, one of the things we're going to do is assess neurological status. Are we going to do a full-blown neurological assessment, cranial nerve assessment? No. Can they wake? Do they wake to voice? Do they wake to touch? Do they wake to pain? Are they oriented? Most of the time you will see people that will only be oriented to self and maybe place. Time is not really that much of a problem. We're going to assess for signs of hypoxia and look at their level of consciousness. Remember, in that post-ictal period, it's a restorative period that the body wants to undergo. So you're going to want to let them sleep. That doesn't mean you don't wake them up every 30 minutes or so to check to make sure they're still okay. Doesn't mean that you close the door and don't bother them. You check on them. But you don't vigorously say, hey, wake up, wake up, wake up. I need you to walk around here and do this and all this bunch of stuff. Let them sleep. Post-ictal period, assess your vital signs. I'm going to ask you a question. Do you think I could have assessed vital signs on the guy doing generalized tonic-clonic seizure? No. Otherwise, if I wanted to get hit in the face, maybe. All right. I don't care what his blood pressure is. What I care about is he breathing or not? That's the only vital sign I really want to know during the seizure. And I'm going to tell you, a lot of times they don't. But they typically, for about 30 seconds, there's a period of apnea. But they do usually start breathing again. Okay, as that tonic phase ends and the clonic phase begins. Tonic, usually there's a period of apnea. With clonic, they usually start breathing, and it usually is a very noisy respiration. okay? If I can hear them breathing, I know that they're okay. Safety is one of your key things. You noted in the bed, those were padded, okay? They make side rail covers. We don't want to engineer our own with bed pads. Side rails probably are going to be 4 up on these patients. Yeah, I know it's a restraint. But it's a safety issue with your patients with seizure activity. You don't want them to fall out of the bed. Now, what if they're in the chair when they start having the seizure? What are you going to do?
Get them to the floor.
Get them to the floor. How are you going to protect their head? Put their head on your lap or on a pillow in your lap. Okay? Typically, what you should do is get them flat, turn to the side, and try not to restrain movement, because you will break an arm if you try to restrain their movement. Yeah, you may hold them enough to keep them from falling out of the bed or falling out of the chair or whatever, but don't restrain their movement. Now, let me ask another question. Do I use a tongue blade?
No.
No. Why not? Because I'm going to tell you, I've seen people do this, and I've seen really bad injuries from it. People think that I need to put something in their mouth so that they don't bite their tongue. They bite their tongue, that's okay, it'll heal in a day. But don't put your finger in there, because I have seen fingers bitten to the bone because of that. I have seen metal pins bitten into. Typically what happens is that it breaks the pin, it breaks the tooth, and then you've got to worry about where did that tooth go. Okay? Do not use tongue blades. We do not want to put anything in the mouth that may obstruct our airway. Okay? All right, so let's take a 10-minute break, and we're dreaming or not paying attention in class. Okay? So absent seizures, typically, like I said, 5 to 30 seconds of just sort of staring off into space and maybe a little eye twitching, but that's basically what you'll see. Now, tonic-clonic seizures are the generalized big bads. Okay? They used to be called grand mal seizures. This is the most common type that you will see in adults. Typically what you will see is that they will have an unusual sensation or uneasiness prior to the seizure. Again, that's what those seizure dogs key in on. Basically with tonic-clonic seizure, they present with a loss of consciousness. There are 3 phases. You see tonic, which is the stiffening, the clonic, which is the jerking, and the post-ictal period usually is a period of decreased level of consciousness, and all they want to do is sleep. Think of that as reparative. It's restorative because of that high metabolic needs that those patients undergo. Post-ictal is a recovery period, and we want to provide them with that. Glucose and oxygen deprivation is common during the seizure because remember the brain cannot store glucose and oxygen. So typically the longer the seizure lasts, the more likely you're going to see a depletion of those in your patients. Okay, so now this is what a tonic-clonic looks like. Just thought he was just a weird guy. Okay? And that's one of the things that you'll see with a lot of the temporal lobe epilepsies. is that they are all those automatic movements, that mouth movement, the lip smacking, those types of things. Okay? So let's go to the next slide. Absence seizures. Okay, absence seizures are a generalized seizure. Basically, you have brief cessation of all motor activity. It includes both hemispheres. Blank stares are often common, and the person is generally unresponsive to voice. They are more common in children. They tend to run in families. They're usually only about 5 to 30 seconds long. These kids may look like they're daydreaming, and often they're misdiagnosed as having ADHD or ADD. Or they just don't pay attention in class. Very difficult to do those schoolwork whenever you're having 5 to 10 second losses about every 5 to 10 minutes. This child that was having the 200 seizures a day was having absence seizures. And what you will see is that with these, there's no warning. They just happens. They just sort of stare off, and you may see eye fluttering, and that's about it. Basically, what you're going to see with these kids is they have what we call no post-ictal confusion. Ictus basically is seizure activity, okay? So after the seizure, there's no confusion. They just go right on with what they were doing prior to their seizure activity. Typically, what you'll see with absence seizures is they are commonly occurring between 4 and 10 years of age. The majority of time, they resolve by the age 20. Okay, so let's look at see what an absence seizure looks like. In intracranial regulation, we're talking about seizures, and then we're switching to sensory perceptual and talking about eye stuff. Today, at the end of class, I will have a few minutes for those of you that have questions about tomorrow's test in management, okay? So just sort of hang around at the end if you've got any questions. I've also been asked to talk to you about math problems that you might see tomorrow. I'll be glad to do that as well. Okay? Do not forget that we are now following the schedule that was posted. Today we'll be doing, as I said, intracranial regulation, sensory perceptual. Tomorrow is the management test. There will be a couple of hours of class after that, and possibly clinical prep. It will depend on what the temperature in the room is going to be. If we do have clinical prep, basically it will be to make up class time. Okay? So that I don't have to post 100,000 things on the website for you to do independently. The content that I am going to post to make up for those 3 hours that we missed last week will be related to healthcare systems. It'll be Medicaid, Medicare stuff that you just need to have a basic understanding of, but nothing in depth. Okay, so I will be posting that, and it will be an online assignment. We will start with the content that I posted for last week tomorrow after class, if the temperature does allow us to do so. All right, do not forget, Ms. Rummels' cardiac test is next Tuesday. I know. It's not that bad a test. I've seen it. Oh, cardiac, for God knows.
Yeah.
But I did not. I thought it was fair. Let's just put it that way. basically, after that, we will finish up the rest of the eye information, and then we will send you off for Happy Turkey Day. So, just one day of class next week, just Tuesday, okay? All right, so here we go. Basically with seizures, what we're talking about is, oh, don't tell me these things before. All right, seizures. Basically what you're seeing is an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that results in alteration of consciousness, motor or sensory ability, and or behavior. Okay? Basically what you will see is that there are differing types of seizures, but what you often see is that these areas of the brain that have that uncontrolled electrical discharge are rapidly firing, okay? Basically, one of the things that you can think about is that those areas that control the seizure, basically their metabolic rate increases by about 400%. Okay? 400%. So what you're seeing is a drastic change in the amount of glucose and oxygen that's needed for that area of the brain. Now, with seizures, what you're going to see is that they start in one area of the brain, and they can be confined to that one area, or it can spread throughout other areas. By definition, a partial seizure is only on one side of the brain. A generalized seizure includes both sides of the brain. They can be primary or idiopathic, where there's no identifiable cause. Something may have occurred that causes that seizure, but there's not a specific point in time that the physician or family is able to identify they had this seizure because they had a head injury. It just sometimes occurs. Sometimes it can be secondary or from metabolic disorders. Now, these are the ones you're going to see most often. Hypoglycemia, acute alcohol withdrawal. You're going to see also electrolyte disturbances. Low sodium, high sodium can cause seizures. You're going to see it from cardiovascular disease, anoxia, infection, exposure to toxins, traumas, tumors, with toxins, sarin, cyanide, pesticides of all sort will cause seizures. You can also see it from vascular abnormalities, because if you think about it, those can cause anoxia of the brain. Okay? So primary or idiopathic is probably going to be the cause that you're going to see most often. Now, one of the things that you'll see is that these metabolic causes that I've just gone over are what we call non-epileptic seizures. Mm-hmm.
You see primary or secondary metabolic?
You see idiopathic. You don't know why.
Okay. But
more often than secondary. At least in my practice in neuro. Okay. Now in general med surg, you're going to see these secondary from the metabolic causes. A couple of other things that you may see cause non-epileptic seizures are non-ketotic hyperglycemia. Remember, whenever you're talking about hyperglycemic episodes or DKA. Remember, there's also that HHNKS, that non-ketotic syndrome. That typically will cause seizures. You can see it from hypocalcemia, hypomagnesemia, hypoparathyroidism, hyperthyroidism. But the one that we see most often for your metabolic cause is going to be drug intoxication or withdrawal. Cocaine is one that you see that causes seizures quite a bit. Now, when you're talking about seizures, by definition, epilepsy is a syndrome, okay? By definition, it's chronic neurological condition characterized by recurrent episodes of non-metabolic causes. Typically what you'll see is that for a diagnosis of epilepsy to be, it has to be 3 or more seizures of non-metabolic causes. One of the things that you'll see is that about a third of people with epilepsy continue to have seizures despite treatment. One of the things I did in my earlier practice is worked in one of the epilepsy centers where they did monitoring. We would have kids come in that would have upwards of 200 seizures a day. A day. All right? Even despite medications. Which, basically, if you think about it, how functional is that child going to be at 200 seizures a day? Not very. Basically, remember, whenever we talk about seizure, you're going to see it on EEG, okay, as spiky waves, okay? Any of you been into the Epilepsy Monitoring Center at Northeast? Okay. It's a pretty good indication of what they do with epilepsy monitoring. What they do at Northeast that's a little different than what my epilepsy center did is that they use external electrodes, okay, and do monitoring. It's 24-hour video recording as well as EEG monitoring, and they're hoping what they capture is an event, okay? Typically at Northeast, they do not say seizure. It's an event because only the doctor can say if it's a true seizure or not. What we did at Duke that's a little different is that in addition to that, once we had sort of figured out where in the brain that seizure was coming from, we would take electrodes and place them in the brain that had different depths, sensors on the depth of the probe, and then monitor from that as well. So that we could get very, very specific, because you don't want to go hacking out hunks of people's brain that you don't have to. But if you're able to get a very specific small focus, they're much more functional after that epilepsy surgery. Epilepsy, again, 3 or more seizures of non-metabolic causes. All right, so let's talk about febrile seizures, which is something that you will see in children. Okay, it occurs in children as a result of a rapid temperature rise above 102 Fahrenheit or 39 degrees Celsius. Typically, what you will see these is between age of 3 months and 5 years. What you see is a generalized tonic-clonic seizure, which in the lingo is termed the big bad. Okay? Basically, these are the ones with jerks, and it's a generalized seizure. Extremely scary for parents. What you typically see is that febrile seizures occur on the first day of that fever or illness in susceptible children. Typically what you will find is that these tend to run in families. So if you have a child that had a seizure because of fever, then your subsequent children are also at greater risk for febrile seizures. What you often see is that peak incidence of this is between 17 and 24 months of age. Okay? Children that experience febrile seizures have a 30 to 50% greater chance of experiencing a future seizure of some sort. A lot of these folks tend to develop generalized complex partial seizures or temporal lobe seizures. Or if they have exposed to alcohol or cocaine or other drugs, they would be more likely to seize than the general population. Basically, what you're going to see, however, is that 95% of these children that have febrile seizures do not develop epilepsy. They have this period where they have these seizures associated with fever, go on and live normal neurological lives. Okay? So it is one of those things that if a febrile seizure occurs, we don't treat them with anti-epileptic drugs. What we do is highly recommend to parents, when you start seeing this kid start to develop a fever, you give them Tylenol or Motrin and keep that fever down. Because if you're able to keep that fever down, then that child is not going to seize or is not likely to. However, they can still have seizure activity. Typically, what you're going to do with children that experience febrile seizures is a lot of teaching for family members of safety and observation type things to make sure that that child is kept safe, making sure that they're getting their antipyretics so that that fever does not rapidly rise. It's not at the peak of that temperature, it's how rapidly it goes up. Okay? Questions about febrile seizures? Will they occur in adults? No, not usually. I've never seen them in adults, and I've never seen the literature say it was. They're usually in children only. Okay, so let's look at classification. Used to be that they would call them petit mal seizures, grand mal seizures, and you may hear that terminology still used some places. But what most neurologists, neurosurgeons, and the rest of the world have gone to is this international classification of seizures, where you're going to see partial seizures as simple partial or complex partial. Think of a partial seizure as a seizure that only involves part of the brain. Okay? It typically does not cross the midline through the corpus callosum. Generalized seizures do cross. It involves the entire brain. Typically what you're going to see, the difference between the two, is with generalized seizures that involve the entire brain, you're going to see a decreased or a loss of consciousness. With partial seizures, you may not see a loss of consciousness. Okay, so let's look at some of them. Simple partial seizures. Seizure activity is confined to one part of the brain, and basically this is what your client's going to assess like. They're going to remain conscious. They may report an aura. Okay, and what do I mean by aura?
Something happening before.
A funny taste, a funny smell, a weird feeling, okay? And those things are what a lot of people are able to recognize once they've had them 2 or 3 times. Recognize I need to sit down, I need to be able to make myself safe, okay? That is also one of the things that you will see that seizure dogs are tuned into. They can take, there's a change in the sense of smell, or the smell that this person puts off, or increase in anxiety, and that seizure dog knows to pull that person down so that they'll sit. Typically with simple partial seizures, you will see tachycardia, hypotension or hypertension, just a change in blood pressure, flushing, a sense of deja vu. And what does deja vu mean? This has happened before. Okay? Did that just happen? Yeah? Well, it happened again. Okay? Those types of things. You may also see inappropriate anger or fear, okay, to the situation. With simple partial seizures, typically what you will see is that there's no alteration in that level of consciousness, and you may see tonic contractions. Tonic meaning stiffening, clonic meaning jerking, contractions of the face, fingers, feet, and it marches to other muscle groups. For example, a lot of times what you will see is a facial okay, like that. Just one-sided. And you may see facial tics, twitches, arms jerking, okay? How can I tell the difference between seizure activity and just muscular contraction? Any idea? Or a tremor? Jason's doing it. You put your hand on it. If it continues, it's seizure activity. If it's tremor, it will stop. Okay? Basically, what you will see is that sometimes even simple partial seizures can be sensory in origin, meaning that they only smell a particular smell, flowers, fish, or rotting flesh. Okay, complex partial seizures. Complex partial seizures are sort of the fun ones, so to speak, for those of them people that don't have them. Because these are a little bit more difficult to evaluate, and they are a little bit more complex. Basically, what you will see is, you may hear this referred to as temporal lobe epilepsy. Usually what you will see with temporal lobe epilepsy is what we term autonomisms. Automatic movements, like lip smacking, head rolling, and you may see swallowing, arm or leg movement. I had one patient, we thought he had OCD, but actually his autonomism was he washed his hands repetitively during his seizure. And it wasn't until we had EEG leads on him that he had one of those hand-washing seizures, and that's what he did during a seizure. I had one person that packed and unpacked their suitcase. Had one person that was stripped naked and marched down the hall. That was fun, especially since she was the preacher's wife. Okay? Typically what you will see is that temporal lobe epilepsy is preceded by an aura. that unusual smell, or sudden intense emotions. Typically what you will see with a lot of these people is fear. You may see decreased consciousness for hours. Remember, I told you that brain activity increases by about 400%. Think of running a marathon. What would your muscles do? They'd be very tired, right? So with that increased metabolism of the brain, typically you're going to see that decreased consciousness for hours to repair that tissue. Typically what you'll find is that these people, after their seizure, do not remember what they did. Okay? 70% of partial seizures are temporal lobe seizures. Auras are common, and that lethargy before they have the seizure is also very common. So let me see if this is going to work. If not, we will copy it. All right, that's not the... Skip the ad. Why?
Because he has, look.
His mouth.
Look.
You do a documentary on you.
Look at his mouth.
We're gonna send it to Dr. Phil and make millions of dollars.
Oh,
What do you see? What is it? What do you see, Bev?
besides the handsome young man.
Who's that? Okay, so this would be complex partial.
It's for the